Good morning to all of you. Today Dr. Nazima is not there, so I'm filling up in her place. This is one of the talks that I took just last year, only in October, from AMSP Manipal, for which thanks a lot to Dr. Suchitra and Dr. This is regarding what the because in that talk there were diagnostic perspectives from the clinicians. So what is a microbiologist perspective of diagnostic stewardship? So regarding that, I just want to put a few disclaimers that we do stress upon automation, but we do not promote any kind of brand. All the antimicrobial stewardship policies and methodologies are customizable according to our own setup, the way that you want to set up, and some methods are different and sometimes even radical at times, but every step is significant, and I'm primarily sharing my personal experiences. So most of the people, especially the clinicians, are not aware of the term steward. What does steward mean? So if you go to a restaurant, you get to see two kind of people. They both look the same, but one is a steward, one is a waiter. So the waiter will just give you, is a classical benchtop microbiologist. He'll just get a sample, he'll give you the report, nothing else. That is just the old thing what happened. Then what a steward is, who customizes the reports for you, who tells you what is to be given, what is the best for the patient. For that, he will require a lot of data from you. So a steward will ideally ask you that are you intolerant to lactose? Are you allergic to any particular foods? Does any seafood makes you nauseous, or you want your food to be spicy? So all these things, your entire menu gets customized by a steward. So that is the purpose of steward. So it is not, because every patient is different, so that's why you have to customize the reports according to the patient that you are dealing with. What is the clinical interpretation of the MIC? What are the PKPD based interventions? What are the dose monitoring based creatinine based on creatinine clearance and LFTs of the patient? You have to accordingly change the dosage of the aminoglycosides and the other drugs also. Active hospital infection surveillance scoring also has to be done. Bundle based management of HA has to be done. That's a very critical aspect of hospital infection control program. We have to give them information about what are natural resistances in the bugs and what is the existing antibiogram. We are now building up on our existing antibiogram starting from scratch, and of course we have to put up all what are the different drug and drug to bug interactions. So basically we have to do a lot of interactions, and a lot of education and teaching programs have to be done in case of stewardship programs. So the role of microbiologist is not just now limited to the diagnostic lab, it is way ahead of that. Like you need to have the knowledge of the anti-infectives, you have to be an epidemiologist also for when it comes to infection control and prevention of hospital-acquired infections. You have to be proactive in early diagnostics, because infection does not take any holiday, there is no Sundays for infections, so you have to do 24/7 reporting is to be there, 24/7 lab has to be there, 7 days a week lab has to be there. And besides, you have to take around like what is happening in the UK in the NHS is that the microbiologist is not there on the seat. After the seat, they go and visit the wards. They go and take bedside rounds. They discuss with clinicians. They follow the patients also. And of course, one critical aspect is the quality control parameter when it comes to the implementation of ISO 1510/2012. And of course, the molecular and diagnostic research is also. So all these is the entire paradigm is now shifted. The microbiologist got much wider role in fact, NABH accreditation cannot be taken without the microbiology lab also. So these are different kinds, like the conventional benchtop microbiology is totally over now, and now it is the era of the infection disease steward, and it has got multiple things like antimicrobial stewardship. They provide you the drug choices there, drug dosing, PKPD based management, therapeutic index or therapeutic efficacy based reports. There have to be clinical footnotes, intrinsic resistances. So this is the antimicrobial stewardship. Most of the things that we are all following in our lab as of today. In diagnostic stewardship, we have to go in for active reporting, not just proactive, not just passive reporting. We have to call the clinician, talk to them, find out what are the symptoms of the patient, what is the samples, what is the specimen is like. You have to go in for automation, accreditation and quality control, emergency reporting, 24/7 reporting, and provide them with critical alerts. And you have to interaction. You have to do a lot of interaction with the clinicians, patient follow-up, and of course the pre-analytical step, because what we call as a GIGO, that is garbage in is garbage out. So whatever the specimen that you are getting, that specimen, not only the specimen, even the patient history is extremely critical, because what kind of colonies or what kind of pathogens you're processing, whether they're pathogens, they are colonizers. We have to be dead sure about that before releasing the AST report. And of course, the hospital infection control steward has to be closely involved with infection controls, with surveillance, hand hygiene programs, training of the ICNs and the healthcare workers, and of course the disinfection policy, CSSD involvement, and management of sharps and needles and sharps have to be, management also has to be seen, biomedical waste, and of course miscellaneous like STP and effluent treatment plant. So what are the host factors which have to be considered by all stewards is like what are the patient features, what are the renal functions, what are the MICs, and what is the core area for intervention is the source control, and of course availability of the drug for the patient in the hospital formulary. So other than that, like you have to look at the age or the weight of the patient, because one size does not fit all. You have to look at other comorbid conditions like diabetes and any other chronic immunosuppressive disorders. Whether the patient is on chronic instrumentation or critical, semi-critical or non-critical instrumentation has been there on the patient. What is the duration of the instrumentation, the patient's liver and kidney function tests, the drug availability, competence of the healthcare worker, what we call as the entrustable professional activities or the EPA. That has to be done very carefully, because you must know before your intern or your GR is able to insert a catheter or not, whether he is able to use the sterile technique or not. So you have to first check whether he is trustworthy to perform a professional activity, like basic thing like putting a catheter on a patient or taking a specimen from a patient. And of course you need to have a robust IPC. So what most of the things that we often consider, but at times we don't consider what are the MICs, and unfortunately right now in our setup we don't have MIC based reporting systems right now, so we are just doing the AST based on the Covey board distribution method. So there is a fourth kind of steward, what we call as a community steward, which is primarily dealing with the health hygiene, the hand hygiene awareness, cough etiquettes, immunization, antibiotic misuse. In fact, in my previous institute, I had initiated this program, the Kids Initiative Program, or the Kids Infectious Disease Surveillance Program, where we had an awareness arm, the surveillance arm, the prevention arm, and we had circulated this through the director to all the schools in Noida, and we had tried to start this thing. Then unfortunately, just after that, the COVID pandemic happened, and this unfortunately could not get implemented. So there's a vicious cycle, like we are all involved in that. We have got heavy workload is there, and there's incumbencies there. We are not able to go out of our labs. There's compromised health quality control. There's no accountability. There's lack of education and awareness among about the antimicrobial stewardship program. There is of course misuse and overuse of antimicrobials is there, and the national action plan it is there now coming up, has become made compulsory to curtail the use of the overuse of antibiotics or the misuse of antibiotics. And of course the AMR surveillance is extremely important, and we are in the process of planning a statewide AMR surveillance program under WHO also. So this is a vicious cycle, and somewhere we have to break the cycle, and multiple core elements are existing by CDC, and multiple declarations have been done like Chennai Declaration, Jaipur Declaration, Delhi Declaration. All these guidelines are existing, but basically we are not able to break this vicious cycle unless we start implementing some basic simple steps like active reporting or putting up our clinical footnotes and customizing our AST reports. So in textbook you'll find a lot of theoretical concepts which they look good in print, but we need to have a pragmatic approach. A lot of literature is existing. It's always nice to take ideas from them and then customize according to them, case wise, depending on what kind of healthcare settings you are coming from, and whatever that you can practically do in your setup. Don't try to emulate or just try to copy whatever has been happening over there. You have to customize your own AMSP programs. And we all have limitations, and we have to look for solutions and not harp on the problems, and learn from real life situations and experiences and mistakes. And every time the main purpose is to save the patient of. So basically you have to aim small, then only you will miss small. So you have to have a very targeted aim, so only then you are likely to get your target and miss small. So there are guidelines existing like this the ICMR guidelines there for the AMSP implementation program are there. They are very good guidelines, but you cannot adopt the entire guideline in toto, so you have to go step by step. Then there are multiple practical toolkits available by WHO in 2019. Then there are toolkits available specifically for developing countries, are also available through from WHO, from CDC, from British Society of Antimicrobial Chemotherapy. But these two are very good and practically adoptable. This has already been implemented in some areas, and this is what we are also adopting in our institute also. So what I'm trying to say is that when I say that aim small, miss small, is that you have to take baby steps and not try to confuse and compare and complicate your entire AMSP program. Don't let it look like this. You have to just pick up a small specific area and then work upon that slowly and involve the other areas in the hospital. So now the issue comes with that antimicrobial stewardship in resource limited settings. These are the pretexts on how not to implement. This is a very negative slide. This is a very negative slide, yes, but it is a fact that how not to implement, that how to, so there is no automation. I don't have any automation. What do? How can I rapidly diagnose? I can't do that. So there are multiple pretexts which people keep on giving. I've got no trained manpower. In my previous institute, I was working without SR for 5 years, 5.5 years, but still I was able to do reporting on Sundays also. So you have to have, yes, definitely faculty has to work, SR should be there, but then at the same time, if they're not there, then we have to work on our own also. We should have a 24-hour round-the-clock lab for microbiology, because please remember that microbiology is, I was asked at one time by my professor, long time back, that what is the emergency in microbiology, and today I can step out and say, tell me the sepsis is not an emergency, right? Any kind of severe infection, any erysipelas, any kind of wound infection is not an emergency. So every emergencies are there, right? So administrative support can be developed only when you try and convince the administration that yes, it is definitely an emergency, we require support. Pharmacology support is most important and most critical for clinical microbiology, and there are places where there is no HIS and LIS. So ultimately you'll have to call up. Now fortunately we have got mobile phones, you have to call up the clinicians, talk to them, discuss with them, and then you have to start documenting your data through any digital software that you can do it from on Excel. I've been using Excel for WHONET for the past 15 years almost. So WHONET is an excellent program to document your AMR and AST data. So basically you need to talk to a clinician, define a critical alerts. We have defined a critical alerts in our institute. We have made a formal document for that. We are already providing advisory services on the AST reports, and we are sending the AST reports both digitally also we are sending, and through the manually also we are sending. We are also reporting that this is definitely this is a pathogen, this is an MDRO, this is MRSA, this is to be done, this is MSSA, this is not to be done, this is an ESBL, this is to be done. So we are sending all these alerts on our reports. You have to establish your AMR recording, like I said, you have to install WHONET and enter your entire data digitally. And WHONET entry is very, very critical in the sense you have to cleanse your file, you have to check multiple times that all the entry has been done correctly, because the patient demographics, if they are not entered properly, and that is the challenges that we are facing right now, that we don't have the entire demography of the data, so we have to search and scratch and multiple things. You have to look at the forms, call up the clinicians, look at our HMIS and all these places, and because patient has got multiple entries on the HMIS, so that's why you're not able to pinpoint which was the exact department which has sent the requisition for a particular specimen. So there are certain issues that we are holding. We are having some issues, so we are trying to resolve on that. We are also calling up the clinicians and trying to have regular discussions, case-based discussions are there. And we have realized that mostly the surgeons are normally most receptive towards these things. And there are multiple simple methods can be implemented to reduce the turnaround time, like 24/7 reporting and Sundays and all holidays reporting. What I always say is that never reject a sample until it falls in your sample rejection criteria, and sample rejection criteria has to be made very, very objective. Who will accept the sample, who will reject the sample, whether a specimen can be collected, like if CSF is a very critical sample, you can still accept it if it is sent in an unsterile container. You can still do a culture and let the microbiologist decide whether it can be. So don't just reject a sample just because it is not sent in the wrong container. You still have to do the judgment. So sample, in my previous institute, always if I am on the campus, then sample will always be accepted. There is no question of rejecting the sample. So implementing the active diagnostic stewardship, how we can do that, like multiple examples I'll just cite as the presentation goes on, like the critical alerts, the gram-negative sepsis, the prosthetic joint infections. There are various examples I'll be citing, around 10 or so. I'll be citing, of which one I have already discussed in my previous last week's lecture. I'll just quickly browse through that. So this about the CRE infections, how do we treat salmonella, what are small colony variants of Staph aureus, what is the power of observation and vigilance, how you can implement the PKPD based treatment in clinical practice. Preoperative surgical prophylaxis. One thing is very, very critical that is lacking in most of places. People don't realize what is the meaning of prophylaxis. Parenteral to oral switch and documentation of the data on the WHONET. Now what happens when we don't practice diagnostic stewardship? What happens? Now this is a classical or a typical example from a government microbiology department that on Thursday in the evening at 6 p.m. a 60-year female with suspected sepsis. Now sepsis is an emergency, is admitted in the ER. Blood culture is taken in a manual BHI bottle and sent to the lab at 7 p.m. Now what happens is the lab normally closes at 4 p.m. so we will not take the sample, right? Sample is not accepted after 3 p.m. So that is closed. You'll see this is what exactly happens. Sample arrives on the next day, that is on Friday at 10 a.m. in the morning and gets incubated, and on the next day, that is Saturday, after 24 hours incubation, blind subculture is made on sheep blood agar and McConkey agar, and there is no turbidity is not noticed on gram stain, and no gram stain is made during the subculture also. On Sunday, you get a growth which is positive for gram-negative bacilli, and again it's a holiday, so the lab is closed, so you won't do any reporting. On Monday, there's a manual ID and AST is put up. That is because we got a manual system and carryover distribution, and still the pediatrician has not been informed that a gram-negative is growing over there. And by Tuesday, reading and done, the report is dispatched. So this is a classical example of passive reporting. This is what is passive reporting is all about. And Tuesday by 3 p.m. the resident has already made the death certificate. So that is the unfortunate part that we are actually facing in a government setup when we are doing passive reporting. That's why I'm saying again and again that a microbiology lab has to be a 24/7 lab. So what should we do is in this case is that you should ideally accept the sample at 6 p.m. or maybe at 7 p.m. you should accept the sample. Advise the clinicians to go in for a procalcitonin or maybe a CRP in the emergency lab. Then you have to notice the headspace turbidity. You accept the sample on Thursday only. On Friday, you notice the headspace turbidity, make a gram stain. You'll find gram-negative bacilli and you put up a direct AST and inform the clinician as early as possible. And by evening, on Friday next day, you can still see on the direct AST. Now, direct AST protocol is still existing in CLSI as well as in UCAS. So you can follow both the criteria and put up your AST. So you can put up your direct and manual AST can you put up. And so sepsis is a medical emergency. Sepsis is always, and I always say, I cannot stress more than this, that you have to have a 24/7 microbiology lab, and this is the reason why we got it documented from the competent authority that this is the area demarcated for a 24/7 microbiology lab. You should always try and keep automated blood culture in the bedside, because one of the very state of the art, I would say, Institute of National Interest, I audited in NABL, and they had kept a continuous blood culture monitoring machine on the bedside, and they used to take the sample immediately, put it over there only. The moment it came positive, they used to send it immediately to the microbiology emergency lab. So the active clinical microbiology reporting is the norm, and that can be that can be done even the absence of automation. So question is that you have to accept the sample 24/7, because for every delay of 1 hour, there is a decrease in the survival rate of by 8% almost. So the chances of survival keep on going down if you are not detecting the pathogen and reporting it on time and starting the right antimicrobial therapy for the right bug for the right patient. Now, do you observe? Now we are doing manual right now. Maybe a few months from now, we'll start our automated systems. But in the manual method, do you observe headspace stability? Yes, now we have started doing it on a routine basis in our lab, because headspace stability, you will be able to see that some growth is there without shaking the bottle, get them out of the incubators and make a gram stain. You will find out that there will be gram-negative bacilli, and you have to report it as a critical alert. This is a list of critical alert that we have also implemented in our institute, that if we get a B positive or the BHI bottle is turbid, we make a direct gram stain, put up a direct AST. If we see GPC in clusters, we can put up tube coagulase along with a control stain of 24923, and subculture can be made on blood agar with vancomycin disc. And if we see GPC in chains in any of the turbid bottles, we can put up biolespilin along with 29212 ATCC and inform as early as possible to the clinician that this is what we are getting. So these are the critical alerts that we are now implementing in our college also. And of course, there is a distinct advantage of residential proximity. Now this is the situation in my previous institute. This is the balcony of my home, and that is my lab, and it is so close by that in the lab my laptop used to catch the Wi-Fi of my home. So there's a distinct advantage that if you are staying on campus, if you're staying, so you don't feel troubled if you have to come to report and do reporting on Sunday. So resident proximity of, if you have a resident, that's the reason of the word resident is there. If a resident is there on campus, he can come and do the reporting for you also. The pre-analytical issues are very, very critical, because I said, I've been saying this multiple times also, and we trained the ICNs also last month also, that blood culture is to be the first specimen to be collected as per guidelines. This is as per the guidelines of CLSI, that blood culture is of once you have to collect multiple specimens from a patient. This is a chart that has to be put up, and all the collection sites, the blood culture is to be collected as the first specimen, and at least 10 ml of blood has to be taken, and mixing has to be done. This is one inversion, has to be done 8 to 10 times, and then all pre-antibiotic specimens have to be taken, not just blood cultures, all specimens wherever you are suspecting, like for an abscess or any, if you are suspecting pleural effusion or pleural tap, or maybe a sputum also. In that case, you have to take it, all samples have to be taken pre-antibiotic, and there are specimens which can be collected in automated blood culture bottles directly, normally samples which are from sites which are normally sterile, like blood, CSF, pleural fluid, pericardial fluid, synovial fluid, all aspirates which are collected aseptically, intraoperative biopsy and tissues, and now we should start replacing all our manual with only automated, because our turnaround time drastically decreases and we are able to give the reports very soon. So enrichment must be made compulsory for all these specimens which are from normally sterile sites. So the absolute essentials for diagnostic stewardship are that we need to have 24/7 sample acceptance, that is the pre-antibiotic samples. So until we don't have 24/7 sample acceptance, the clinician will wait. Okay, how can I give the antibiotic when the sample is not being accepted? So we have to have the first thing, that sample should be able to accept the sample. If you can't accept the sample, the patient can't wait for long for any empirical antibiotic to be given. So blood culture has to be collected before anything else. Besides specimen plating, wherever possible, you have to cut down all the transportation time. If possible, try to bedside plating, especially like in cases of meningococcemia, when there are a lot of skin lesions, we try to do a bedside plating. You always have to do a gram staining wherever possible, and wherever possible, irrespective whether it's been asked or not. Gram stain will give you a lot of information from your clinical sample, what kind of bugs that you're getting. Specimen enrichment wherever possible, and direct AST wherever possible. And of course, you have to always supplement. You cannot replace automation. You cannot replace distribution totally with automation, and you cannot replace totally manual method with. So we have to go together. They have to supplement and complement each other. I always say that automation and KVDD, that is curry word distribution method, that's the manual AST, are always supplementing and complementing each other. They should both be put together, in the sense that those antibiotics which are not available on our automated panels, additional antibiotics should be put up on our curry word distribution. And there are many things that you can not see on the automation that you can see on the KVDD, and of course 24/7 clinical microbiology lab. Now this is, I'll tell you another case, that's an active case of what is active diagnostic stewardship. We had an emergency lab in MAMC in Maulana Medical College. I was a resident posted over there, and in 2005 there was a meningitis outbreak in Delhi, and I was posted a resident over there. Then the pediatricians, they came up, my colleague from pediatrics, the PG from, and they said we need blood culture bottles because we are suspecting a case of meningococcemia. So he said that okay, fine, I'll try to arrange. So when I saw in my MNC lab, there were no bottles available. So they said the bottles are normally coming from the college building, so you have to go to the college building. So in the evening, 7 o'clock, so somewhere, I took my technician from the MNC lab to the college. I called up the HOD. I called her, ma'am, we need these bottles. She told the guard to give us the keys. We took out the keys, we went to the media room, we opened the media room to find that all the blood culture bottles which were being made that day were already turbid. They were contaminated. So we didn't have any dry media also, there were some issues over there. We took those bottles, we took them to the MNC lab, we refiltered them, we dispensed them again, we re-autoclaved them by time around 10 o'clock like this. So media was finally available. So you have to be proactive when it comes to diagnosis. So when they say that what's the emergency in microbiology, this is the emergency in microbiology. Sepsis, any ID, because like I said, that infections don't have a holiday. So this is the slide that I discussed in my, I demonstrated in my previous presentation also, how there's a rise of the gram negatives, and therefore, and this case also I discussed about the AMSP beta-lactamase last time. I'm not going to discuss in details that how once clavulanic acid, like this augmentin is one favorite drug for all clinicians, how augmentin causes immediate resistance in second. This is the sample taken on 12th March after giving augmentin. On 15th March, the sample became resistant. This specimen, same specimen of enterobitter became resistant to the carbapenems also. So how havoc amoxiclav can cause and create resistance in gram negatives. So that's why you have to try and avoid all drugs like imipenem, drugs like all clav-based combinations. This is already I discussed last time, so I'm not going to go in the details. So this is what I had shown last time also, how you have to, and this is one practice I have been advocating this practice of putting up an imipenem disc in the center, and I am getting multiple messages on my WhatsApp that yes sir, we have started now putting an imipenem disc in the center, and we are getting a lot of good results in the sense that we are seeing a lot of induction and inducible resistance can be seen in different bugs. So that is one practice that we need to follow, and of course you have to put up cefoxitin and imipenem both together. So this is the classical report of enterobitter that normally becomes resistance during the treatment if you don't give the right antibiotic. If you start drugs like imipenem or any clavulanic acid based combinations or even third generation cephalosporins, that has caused a lot of resistance. So ideally in cases of enterobitter cloacae, you should not report third generation cephalosporins, imipenem and clav based combinations. If cefepime is susceptible, please report cefepime only. So in our previous institute, we were doing what we call as a therapeutic index or therapeutic efficacy for all the gram negatives and gram positives that we are getting in blood isolates. Now this is a case of a chronic prosthetic joint infection. This is a snapshot of one of my friends. He's a orthopedician in Fortis Mohali, and he sent me this was a report, Vitek report from a patient's joint aspirate that I isolated. I think E. coli. Yes, it had isolated E. coli. And he asked me that what antibiotic to give in this case. I said that this report is there, so I made a therapeutic index based report I made and sent it to him. He said, no, this will not do. You tell me exactly what has to be done. So what he wanted to know was the actual posology of antibiotics, what to give and how to give. So this is what I suggested him, that this is the therapeutic index based report that I made for him, and I told him that you can, based on this, you can, most effective drug is likely to be piperacillin-tazobactam or cefoperazone-sulbactam and gentamicin in this case. In case the infection does not resolve clinically in 2 weeks, you may give meropenem along with amikacin. So in all beta-lactam drugs to be given as extended infusions only. And IV to oral switch may be done as with ciprofloxacin 70-50 mg BD after 4 to 6 weeks. So this is the report that I made for him. Then he said, no, please let me know exactly what drug to be given and how to give those drugs. So I told him that this is a case of a prosthetic joint infection, so the antibiotic will take some time to respond. Please give it some antibiotic timeout for at least 2 weeks. Normally for bloodstream infections, we give somewhere around 3 days time for antibiotic timeout for the drug to actually, the patient to actually respond. But in this case, you give it an antibiotic timeout of 2 weeks. So I said, I made specifically a dosing recommendation I made for him, and I told him that this is the piperacillin-tazobactam so and so milligram to be given so and so frequently with this drug daily, and how to infuse, when to infuse, what is the total duration. So entire posology I made for him, and this is a second line drug that may be started in this case. So he said the patient is 3 weeks post-operative now, serological markers have come down to almost normal, stitch is dry and removed, clinically knee is silent, could give Genta for 9 days as creatinine started to increase, meropenem infusion going on, and as we suggested, planned to continue for total of 4 weeks. So the patient started responding, and we discussed, and we finally scaled down to oral therapy, because this was a case of, this was around an 80-year-old gentleman who already had, I think he had a aortic aneurysm he could not be reoperated, he was a highly risky case, and therefore they wanted to retain the prosthetic joint. So they could not remove the prosthetic joint, they had to retain it. So that is why they had to put him on long-term antimicrobials, and how to give the antimicrobials, when to give, what duration to give. All these things we discussed, and therefore we came down that okay, the patient was responding, and then finally the patient was went on oral therapy of ciprofloxacin BD4 as per the guidelines by IDSA. This is a case of CRE sepsis with pan-drug resistant Klebsiella. As you can see over here, all these drugs are resistant except for probably colistin, where the MIC is only 0.5. So we suggested, like in this case, what are the kind of, this is a infection control alert. This is the typical report of my previous institute. Infection control alert was given, and CRE has been isolated. Typically it's a PAN or a XDR CRE isolate is there. Extended infusion of colistin along with high dose extended infusion ciprofloxacin sulbactam may be attempted in this case. So this was a neonate. This was a neonate approximately 2 days old. Hospital acquired CRE sepsis. We didn't have a gynecology and obs department. These are all outbound patients who came with neonatal sepsis with CRE infections, and in this case we attempted treatment with colistin and ciprofloxacin sulbactam, slow infusion, and this case also responded. So that is the value of your AST, of your active reporting, the value of the inputs that you put on every report. It's not just that you just report this is SNR and just leave it after this. Normally reports, people leave it after, they don't enter all these things. So we have started this practice since many years now, and this is very, very effective for the containment of for the treatment of MDR infections. Now this is what we call as selective reporting and MIC question based reporting. Selective reporting has now been validated by CLSI M39 document that all reports, and CDC also in 2020 in August had come out with a document that selective reporting / cascade reporting has to be done. You don't have to report all the antibiotics, test all but report only selective antibiotics. Right, so this is a case of these are classical cases of salmonella typhi. Again, in my previous institute, we got salmonella typhi, and we are reporting only azithromycin, p-floxacin, nalidixic acid, cotrimoxazole, chlorphenicol, ampicillin, and ciprofloxacin. We are not reporting any third generation cephalosporins. We are not reporting any amoxiclav. These are all Vitek based reports, but a lot of selective reporting has been done over here. Only the first line drugs, all are susceptible. They are all susceptible. Now these are not defined in CLSI, but you have to define your first line drugs for organism specific definitions have to be done. So in CLSI, all have been given as, some have been given as class A, class B, class C, but then again, if you have to see bug wise what is the actual class of drug, for example, in case of salmonella typhi, AMP, chloramphenicol and cotrimoxazole are first line drugs. No third generation cephalosporins have been reported, no meropenem, no mecacin, no. And of course, we have also added things like for footnotes from CLSI, like Salmonella and Shigella aminoglycosides, first and second generation cephalosporins may appear active in vitro, but they are not to be given. Unfortunately, there are studies which have published the susceptibility of aminoglycosides in tricycle. We published a paper and we have sent a rebuttal about that these antibiotics should not be reported from blood. Like this is one of the caution that we have sent, that in Indian isolate, because we don't have Indian data per se, Indian isolates, the rationale of azithromycin has to be done very carefully, because there is around 20 to 25% resistance has been seen, or higher MICs are seen in azithromycin. So azithromycin reporting for salmonella also be done very carefully, because there have been cases of critical non-response. Now what we call about vigilance is what the eyes see is what the mind knows. Right? Like I keep on saying that swabs are the worst specimens for any culture-based diagnostics, except when you're looking for group A streptococcus in the throat or group B streptococcus in the high-vaginal swab, or you're looking for gonococcus in females. They are the only cases where you can take swabs. Otherwise, swabs are the worst specimens for clinical microbiology diagnostics. And should we process every bacteria that goes from superficial samples? There was a very interesting paper that was published a long time back. They had actually done some kind of testing. They had sent urine culture to different labs, and many of the labs, they all isolated group B streptococcus. There are certain labs, they reported the entire AST of this group B streptococcus, but there was one lab that just said that this is representing the probably group B or a streptococcus agalacti colonization of the high vaginal area, and therefore full AST is not to be reported. They only reported penicillin susceptibility, and that's it. So that is how you're supposed to report. So you don't enrich every sample, but at the same time, if you are getting any kind of tiny growth from aspirates, tiny growth or small growth you're getting from samples which are getting from normally sterile sites, in those cases you have to keep a keen vigilance, keen observation. Patient's history should be there, and antibiotic history should be there for critical diagnosis. Like again, this is a very interesting case of commonly acquired case of small colony variant that we isolated from a 3-month-old child who came with an axillary abscess, and then we had these small tiny colonies growing after 24 hours, very tiny colonies growing, and it so happened that on the same plate on blood agar, one side we had classical colonies of Staph aureus, and other side we had these tiny colonies. So we allowed them to grow overnight. So this is 24 hours, 48 hours, and at 72 hours we got classical growth of these small colony variants of Staphylococcus aureus. I can say with challenge that you will not be able to find photograph better than this with the classical fried egg appearance of the small colony variants of Staphylococcus aureus anywhere on the internet. Now this is a classical case, another of urine culture that we had from a 15-year-old male patient with the ureteric stent with complaints of chronic burning micturition with fever. The urine had numerous pus cells and it grew providentia. Now providentia is intrinsically resistant to meropenem, imipenem, amikacin, intrinsically resistant to imipenem, but it was also resistant to meropenem, amikacin, genta, third genesis phalosporins and non-flox, and only susceptible to piperacillin tazobactam and intermediate susceptible to Pseudomonas salvatum. So what is the clinical decision that can be taken over here? What extra information which is required over here? And just in case most of the people don't read about what is the appendix B of CLSI 100, it is intrinsically resistant to colistin, nitrofurantoin and ticycline, and of course you don't give ticycline in urine. These are the drugs not to be given in urine, and of course it was intermediate susceptible to Pseudomonas salvatum. So in this case we advised the patient to be given piperacillin tazobactam is susceptible. This is another example, same example only. Piperacillin tazobactam susceptible, and we said that pediatric dose is 1.5 to 2 gram IV every 6 hourly by continuous infusion, and loading dose will be given especially when rapid attainment of therapeutic drug concentration is required. So piperacillin tazobactam is one really good alternative, especially for those cases like Proteus, where even imipenem is intrinsically resistant. The tribe Proteae is likely to respond to piperacillin tazobactam. We published long time back that what would be the treatment for carbapenemase producing Proteus, because you can't use colistin. It is intrinsically resistant. So what are therapeutic options are there? Piperacillin tazobactam demonstrated a very good in vitro susceptibility to this thing in the carbapenemase producing Proteus isolates. Another case, real case from that I witnessed in UCMS and GTB hospital. One ENT surgeon, he approached with a problem. It was quite a shock to me that ENT surgeon actually came to my room to talk to me. I was not available. Then he called me up. Then I went. So it is very rare for clinicians to come out to your place, being a microbiologist, and discuss with their clinical case. So basically, he lost 2 cases because of MRSA infection. Both were cases of oropharyngeal carcinoma, and the patient was planned for surgical. They were planned for surgical resection with reconstruction. The patient, they had a very long surgery. These are very complicated surgeries, and it was a long surgery of 6 to 8 hours. The patients died around after almost 7 days post-operative due to MRSA, surgical site infections and septicemia. So I asked him a basic question that what surgical prophylaxis did you give him? So he said it's ceftazidime. So I said why ceftazidime? All these orofacial and maxillary surgeries you normally have a gram-positive coverage. Because it's a practice we've been following. Whatever our bosses and teachers have been telling us, so this is what I've been doing. So there are many blind practices that we are following, and unfortunately no intervention has been done, and it's time to unlearn, and then we have to learn to unlearn things. So did you screen the patient with MRSA carrier? They said no, we have never done it, we have never had this kind of issues, and patient has survived. So we are waiting for certain cases to happen for these kind of interventions to be done, that when to suspect MRSA, screening has to be done. So in all the transplant patients, for all solid organ transplants, for all whenever you are anticipating any implants are being done, for CTVS cases, neurosurgery cases, endocrinology cases, many of the institutes, especially in the US and the UK, they are doing MRSA screening as a part of their PSC protocol. So whenever we are anticipating long surgeries or deep-seated surgeries with implants, we should always go in for a MRSA screen should be done. Now what the issue is that, what is surgical antimicrobial prophylaxis? Let us just understand. It is meant only for elective clean cases and clean contaminated cases, not to be done for dirty cases, not to be done for contaminated cases, and it is only to be given as a single dose. Recently, one of my colleagues shared the surgical antimicrobial prophylaxis for one of the institutes, and they had given prophylaxis for 2 to 5 days. So that is not prophylaxis actually. Prophylaxis is given as a single dose. It is meant to target the local commensal transient flora. It is not meant that if you got a high MRSA in your institute that you start giving vancomycin. No, it is not like that. It is not to be extended beyond the duration of surgery unless it is specified, and this is not to be equated as treatment. This is a classical definition given by the in the American Academy of Pediatrics, that prophylaxis is defined as the use of antimicrobial drug in the absence of suspected or documented infection. Now, when to shift from oral to IV? So this is one low-hanging fruit that we have to think about, that for the implementation of one of the AMSP arms is whenever there is clinical improvement observed, there are conditions which is not a contraindication to oral treatment. When oral fluids can be tolerated, urine output is good, temperature is within normal limits for at least 24 hours. No unexplained tachycardia or a heart rate of more than 100 is there. So all these factors, they are favoring from the IV to oral switch. So if there is a falling or a negative CRP, because CRP has got a very good negative predictive value, its positive predictive value is not that good. Positive predictive value is slightly better for other markers like procalcitonin, but CRP has got a good negative predictive value. If your CRP is negative, then definitely it is not an infection. If the counts are less and you are getting the right drug for the right site of infection, if it is available orally, then you can go in for a IV to oral switch. And when not to shift from oral, when the oral absorption is compromised, for example, if it is a colostomy has been made, right? So the entire oral absorption in the intestinal absorption is compromised. There is continuing decompensated sepsis there, endocarditis, meningitis, encephalitis, vein abscess, these osteomyelitis, these are all deep-seated infections where the oral bioavailability may be 20%, 30%, 40%, we don't know. It may be 70% or even 100% in cases of like drugs like linezolid. But then we have to ensure that we've got a very, very high percentage of oral bioavailability. But in these such cases, we have to make sure that deep-seated infections only and only parenteral therapy needs to be given, because parenteral therapy provides 100% bioavailability. All complicated skin and soft tissue infections, deep abscesses, and all serious bloodstream infections, these are places where you should not attempt from IV to oral switch. Coming to data, now what is data? Like I just insisted that whatever that we are recording on our AST on a daily basis, all the data has to be recorded. Now again, when I was doing my MD, one of our professors said that I want to have all the data of Pseudomonas infection from burn patients. So we used to take the pus register, pus culture register, and we used to start searching, and it was actually committing suicide, because if you want to commit suicide, you have to literally work analog. So I call it not data, I call it mrityu data. Right? So it is very tedious. So you have to digitalize your entire data. And digitalization can be done very easily simply by making an Excel sheet like this. This is I have made before as an alternative to WHONET. You can do this. Like you can have the basic patient demographics, and be here the name, age, sex, IPD, department and organization, and the specimen type. And of course, this violet color is primarily the gram positive panel, and the pink color is primarily the gram negative panel. But of course, there can be overlapping drugs, can be like chlorophenicol, can be in gram positives, amikacin, AMP can be in gram positive. So this kind of thing you can do on an Excel sheet, or you can do and if you are very good in Excel, you can even start entering breakpoint zones, and MICs can also be entered on Excel, and you can have WHONET, which is again a free, it's a raw customizable software. Like I said, I've been using it since 2010. I've been using it. It automatically incorporates the breakpoint zones and both the CLSI zones and MICs, and you can even customize your MIC breakpoints and zone breakpoints. If they are not available on CLSI, they might be available on UCAS, they might be available on the Swedish guidelines, they might be available on the Japanese guidelines. So you can adopt and incorporate. Like recently, we included the piperacillin tazobactam change on our WHONET, how it has changed the MIC and the breakpoint zones. So it caters to all, most of the places it caters. You have to select which are the guidelines that you need to follow, and you can define your entire hospital, lab, location, code, antibiotics, name of the clinicians, everything. All the demographic data can be customized, and we have done it. It takes almost, it is a continuous process. It took us almost like 5 to 6 hours just to customize our lab, put the name of all the clinicians, who are the surgeons, who are the physicians, what are the lab areas that we are seeing. We kept on adding the names of the new faculty. We kept on joining our institute also. We have tried to. And the unfortunate part is that if we don't have this data, we can't enter it on WHONET. So all our demographics have to be present on whatever the forms that we're getting or on our HMIS also. So we have also defined our antibiotic panels. We just revised them recently also, and we have added and removed certain antibiotics. We have changed the breakpoint zones also for piperacillin tazobactam, and we have to define, like I said, we have defined customized critical alerts like CRE, VRE, P-flox resistant Salmonella typhi or Naralytic acid resistant Salmonella typhi, ESBL, etc. And you can always add extra fields, like for example, you can add extra fields on the colony counts, you can add extra fields on gram staining, you can add extra fields like mobile phone numbers of the patients also. So this is all a highly customized software, and it's very advantageous in the sense that all digital data compilation can be done. You can do the line listing of clinical isolates, hospital antibiogram policies can be made, infection control can be done in the sense that you can see area-wise localization of MTROs. Sample collection guidelines also can be seen. Where is the place that you are getting maximum coagulase negative staphylococcus from the blood? This coagulase negative staphylococcus from blood is usually a skin commensal flora. That means your phlebotomy practices are not being done properly. So with the line listing of all the cons isolated, you can pinpoint, okay, this month we have 20 cons from the emergency, we had 5 cons from so and so department. So you know that this is the maximum number of cons. You can see the total number of samples collected versus the against the number of the coagulase negative staph isolated. You can see the percentage. Okay, now we are seeing 17% contamination in emergency. So that is the way we have to focus on the right phlebotomy practices for blood culture. So that is how we can focus. You can also see the temporal increment of the number of what kind of, let's say for example, you're getting Stenotrophona, Smaltophilia from the hospital. So you can see the first case from here, second case from there. So you can track the cases also. So line listing is also possible. There are also auto interpretation and breakpoints, and auto upgrading is also there. Like and it will also tell you alerts. If you're entering Apenem resistant in E. coli, it will give you an alert. If you're entering ciprofloxacin resistance in Salmonella typhi, it will give you an alert. If you're entering gentamicin high-genta resistance in Enterococcus, it will give you an alert. So all these alerts are possible, and you can insert basic comments, and you can link it with all other systems like Vitek and your Excel files. You can integrate your Excel files on WHONET through backlink, and it is secure because WHONET is not linked to any. WHONET WHO does not ask for any data from you. So please, you've been using WHONET because you can convert all your automated systems into a proper policy, and your as a newsletter like this we had made in UCMS. You can have OPD wise and ward wise, ICU wise, and organism wise your data can be given, and as this has to be compiled as per M39 document. And there's amazing stuff that you can do with the cumulative data. Like for example, you can have data for all gram positives and all gram negatives. This is again my previous institutes from UCMS. My data is there. Then you can have organism wise data also you can have. But then you need to have a significant number of isolates for that. You need to have significant number of specimens for that. And then you also have to ensure that whatever that you are entering is a true pathogen. It is not a contaminant or a commensal flora. You can have for organism wise, like for Pseudomonas, Acinetobacter, you can have for Enterococcus, beta-monotic Streptococcus, you can even have sample and specimen wise data also can be calculated, like for blood, urine, pus and purulent fluids, and respiratory specimens. You can have department specific data also in WHONET. Like this is the color coding for pediatrics department, got 491 isolates of gram positives. Ortho has got 40 isolates. Obs and Gynae 372, medicine 492. These are the color codings, and what are the specific antimicrobials that are susceptible in different departments. So this also can be done. Specimen wise data can also be calculated for gram positives as well as for gram negatives also. Of course, you can analyze resistance trends like like these. Like for example, if you start implementing things like hand hygiene, you will definitely see a fall over here. Like we started implementing hand hygiene protocols in 2012, we saw a definite fall in the percentage of crab, that is carbapenem-resistant Acinetobacter and Pseudomonas over here. So this is a common trend that we saw. So you can analyze the resistance trend over the years. So what are the percentage of CREs, what are the percentage of crabs, what are the percentage of MRSA over the years? That also we can analyze. And of course, you can assess your hospital infection control measures like hand hygiene compliance, your stewardship programs, your cohort nursing, restricted antimicrobial formulary, prescription auditing, and critical alert values. Now there are certain measurable components of all your antimicrobial stewardship programs, like you can calculate the percentage of hospital-acquired infections as a daily surveillance or as a point prevalence surveillance. You can go in for the percentage of your MDRO, that is the WHONET data, which is already doing it. Calculation of defined daily dose using antibiotic hang time and timeout. Now what is hang time? Like for example, a clinician has come to the ward round at let's say 9:30 a.m. and he sees a patient and he realizes that okay, it's time to start an antibiotic or change an antibiotic. So if he gives an order on paper at 9:30 a.m. and the actual first dose goes at 1:30 p.m. so that 4-hour gap is an antibiotic hang time, and antibiotic timeout is the time you have to give for the antibiotic to respond, to reach a particular site and to bring out the actual effect. You can also calculate the hand hygiene compliance rate like we've done for your speedy audit app is there, prescription auditing, restriction formulary, and interact two-way sessions. So these these are the ones that we are actually following in our institute also as of today. So certain core components that you can address is that leadership commitment, that we have now been able to actually form a proper antimicrobial stewardship committee. We have spoken to the director, taken his consent, we have formed a formal committee, formal members are there, then there is a core antimicrobial stewardship team is there. We have taken the accountability, we have got a good department of pharmacology from where we can take inputs regarding antimicrobials and the PKPD based interventions. And of course, installation of things like WHONET, critical alerts and advisory reports, so all these things that we are doing at our institute. So also things like tracking the C. difficile infection rate, so you can track down that okay, from where the C. difficile infection has come, so you can go and check the defined daily dosing in that particular ward, wherever it is being done. We have to always come out with things like newsletters, educational programs have to be done like seminars and all these things. You have to be creative and speak to them as early as possible. Now, basic things that clinicians must know about antimicrobials is that most of them they have lost touch with basic microbiology and pharmacology. Like all gram negatives are not the same. There are certain clinicians who even believe that Pseudomonas is a gram positive isolate. Because I have actually seen in a known Pseudomonas infection, they are giving drugs like linezolid. So, bacteremia and lung consolidation, you can give the same antibiotic? No, it is not. A drug concentrating in the urine, drug concentrating in the blood, drug concentrating in the lungs, drug concentrating in the skin and soft tissues, as all they have got different concentrations. All drugs have got different concentrations, so they must be told that what is the best drug for best bug for that particular site is possible. So what they also need to do is to follow the 5 modes of hand hygiene that we are trying to implement through our infection control program. And of course, you have to constantly keep on discussing with them and give on newsletter snippets like these, like what are the bugs which are good for gram positive activity, which are bugs which are for gram negative activity, which are the bugs for anaerobic bacteria, what are the intrinsic resistances, what are the antimicrobials that are the drug resistances which are associated with other resistance patterns also, like if it is an MRSA, then it is also likely to be resistant to erythromycin, clindamycin, amino glycoside. If it is a VRE, then there is an associated resistance also. So all these things also have to be told. What are the intrinsic resistances? We already reporting them on our forms. What are the drugs which are not to be given for certain specimens, and the drugs which are not to be given for certain sites? They also have to be told that tirecycline is not to be given for urine and blood and not for these bugs. Aminoglycosides not to be given for abscesses where there is low oxygen concentration, because the ingestion, the entry of aminoglycosides is oxygen dependent. Not to give nitrofuranide only for urinary samples, and that too only for lower UTIs. For enteric fever, people actually start using aminoglycosides and don't scale down to other antibiotics, like even if they get a culture positive and it's known that it's a salmonella type, they don't scale down to other antibiotics. So we had written a small paper in IJMM that aminoglycosides and tirecycline, these are two misinterpreted choices for typhoid fever. People are still giving it. We had given multiple citations, multiple quotes, and for the studies which are published, which are saying that to give aminoglycoside, it's not to be given. These two drugs are not to be given. So compulsory education and awareness you have to give for residents and SRs and JRs and PGs, like AIIMS Patna has got a compulsory AMSP program is there for all the residents, JRs and PGs who have freshly joined, and it is linked to their salaries also. Until unless they don't attend and they pass after with a certain percentage of marks, the salary is still withheld. Then of course the entire information has to be disseminated. Information is not to be held. disseminate as much information as possible in the form of pocket prints, mobile phones, specimen collection guidelines, display on board on the wards, and continual awareness also has to be done. So we can still practice antimicrobial stewardship and diagnostics despite constraints of being non-automated. This is right now, as of today, we are still not automated, but still we are trying to, whatever that we can implement in our institute, we are doing that by proactive interventions, early interventions. We try to go and visit the wards also. There has to be an extremism in early diagnosis. There are many, almost every Sunday I am coming and doing the reporting also, and also on the holidays trying to come over here and do the reporting also. So we have to follow, it's not just microbiology, it is clinical microbiology and infectious diseases. We are actually back-end clinicians, if not front-end microbiologists. So what prevents us? This is certain, what prevents us from an antimicrobial stewardship program is like ego, incompetency, incompetent, and there is no initiative, no accountability, and no accreditation. So these are the things which are assessed in some of the studies, that what are the reasons for us not to implement an antimicrobial stewardship program. But now it has come under the ambit of the National Medical Commission, antimicrobial stewardship programs, and AMR surveillance, and national antimicrobial, the NAP plan has to be implemented on a compulsory basis for all the medical colleges, including the IIs also. So, for example, like I said, that aim small, miss small. So, for example, if you have to go to, let's say, an orthopedic department, just talk to the consultant in charge, just pick up 1 unit of orthopedics, measure the daily use of the beta-lactam drugs, daily use of vancomycin, post-operative surgical site infection for the clean wounds, make your baseline data, and then implement tools like hand hygiene compliance, education and training, early warning and critical alerts, and PKPD based. So this, if you can just start, like I said, aim small, miss small. So just go to 1 unit, talk to them, discuss with them, implement a basic program like this. So the take-home message is that it has to be aggressive diagnostic stewardship, which is the first step to antimicrobial stewardship program. Download just 3 to 4 objective tools on your AMSP and customize as I demonstrated in the previous slide. Please install WHONET and start using it. It's very easy. The more you use it, the better it will be. Streamline your AST panels. Use your automated and manual AST together. Like I always keep on saying, automated AST and manual AST have to supplement and complement each other. Insert advisory notes like your intrinsic resistances, your therapeutic index reports. Critical values have to be given to them as early as possible. Like if you can see anything in microscopy, immediately examine antigen detection, growth on the media. So once these baby steps are taken, then you can seek the help from your leader, from your boss, and then definitely he'll help you out. Trust the management, and then of course you can also incorporate the CDC core elements, which we also incorporate in our AMSP team. And keep your ego aside, open your minds, and remember that the tortoise won the race, not the hare, right? So it's time to unlearn. It's time to unlearn. We have to study, learn, adapt, teach, and educate. So we have to wipe the slate clean. So that's the stand for slate. Study, learn, adapt, teach, and educate. Thank you so much for your kind attention, please.